Hi there, I'm Jamie Taylor. Welcome to Your Health Matters, brought to you by Kingman Regional Medical Center, your community-owned hospital. Every week on this program, I have a different guest where we talk about different services and programs provided by KRMC. I hope you'll stay tuned because I have a great guest on the program today. We'll be back right after these messages. Welcome back to Your Health Matters. My guest today is Dr. Chris Johansen. Thank you for being on the show, Dr. Johansen. We're so blessed to have you in Kingman, and I don't know if our community really knows how lucky we are to have you. So I want to share with them, first of all, of course, your specialty is the tomosynthesis. No.
Correct. So my specialty is breast imaging. Okay. I did my general radiology training, so I do general radiology, but I did additional training specifically aimed at improved detection of breast cancer. And I was very lucky. When I did my fellowship, there was a technology that was under investigation, and so I was trained on it prior to its release in the United States. It's called breast tomosynthesis.
Wow, I didn't realize that. I mean, I knew that we were lucky to have tomosynthesis here and to have you because you've been trained, but I didn't realize we were that cutting edge.
Well, it was really exciting, actually. We were one of the first places west of the Mississippi to have the technology. We missed the honor of being the very first one by only a couple of weeks to John C. Lincoln, a breast imaging center in Phoenix.
Wow, and that's very impressive because I think a lot of times people think, oh, it's just Kingman, and they don't realize how much KRMC has here that a lot of other hospitals in bigger communities would probably give their eye teeth for.
It's one of the advantages we have of being a little bit smaller hospital. We're big enough that we can still have advanced technologies and specialize, but it's still a nimble hospital. When you see a new technology, we can implement that faster than other places that are larger and have more bureaucracy.
I hadn't thought of it that way. That's a good point. Very good point.
It's actually one of the things that led my entire group to come down here from Mayo originally, is we saw the potential of a place that was big enough to offer any treatment you really need to offer, but yet still small enough where we could have a big impact as quickly as possible, really update things and bring all of the techniques we'd learned and training to help our patients here.
Awesome. And so speaking of that group, I think maybe we should step back for a minute and talk about that full group, and then we'll go back to the tomosynthesis and mammographies again. But so there's 5 of you?
Correct. There's 5, and we're looking at adding our 6th member.
Oh, wonderful.
His name is Jay. He'll be coming down. He's completing his training at Mayo right now.
Wow.
We interviewed several of the residents who are getting done to pick out which one would be the best fit for Kingman and the best fit for our group.
And you guys have been here as a group for a while now. How many years has it been?
Yeah, it's actually been since July 2010, so we're coming up on our 5th year starting this summer, which is amazing. It's absolutely flown by.
That's awesome. Well, and you're all Mayo trained.
Yes.
You've all gone through the Mayo training system.
Absolutely.
And education.
It was back in 2009 when KRMC was looking for radiologists. They contacted the Mayo Clinic to see if anyone was interested. I was the chief resident at that time, so I got the little flyer, and I saw a wonderful opportunity, and not only in the hospital, but in the opportunity to hand-pick the members of the group, which I think really helped out. My partners are not just excellent radiologists, they're some of the most outstanding people that I've ever met, and it's just an absolute honor to be able to depend on them every day and ask their opinion on things, so that when we have a difficult case, it's really interpreted by all 5 of us, not just one person. I was going to say,
it's a group effort if you're that whole team approach, which is amazing, and that collaboration. That's one of my favorite words, collaboration.
Especially in medicine, where it's so important, and it's really a central tenet of what Mayo teaches. I think a lot of people that train in these larger places where there is a lot of collaboration, one of their concerns in going out into the community is that they may not be able to bring that with them. I know that was a concern all of us had as we looked at individual private practice groups across the country, and the opportunity to bring that kind of collaboration to Kingman was really just too much to resist.
Wow, that's awesome. And again, we are blessed to have you have chosen us, or that mutual opportunity for both sides to be good. And so there's 5 of you now, and let's talk about because they each kind of have a specialty as well as their radiology overall.
Absolutely. So one of the advantages is that we've been able to still be a small group, but typically small groups can't offer the kind of specialization that you'd like to have nowadays. We've been able to overcome that by having each of us get a certain degree of specialization.
Okay.
Our president, Cale Bodley, he is probably the smartest person I've ever met in my life.
That's
just
awesome.
an amazing guy and humble. You get frustrated with him because he's so smart. You want him to have some kind of flaw, and he's just he just never presents one. He does neuroradiology incredibly well.
And that, for our viewers, neuroradiology is looking at the brain.
And the spine and the face and the neck.
Okay.
Very complicated areas.
Yeah.
A lot of people have to do a 2-year fellowship to get to the level of expertise that Cale has. He also serves as our president.
Okay.
He's also very involved with helping the hospital in its administrative duties.
Right, yes, he's on the hospital board.
Exactly,
Yes,
exactly. So he contributes to the hospital in a lot of ways.
Right.
Wade Alleman was the other radiologist who came down here originally, part of the original group. He does a lot of musculoskeletal imaging, so joints, anything from your shoulder to your finger. He can take a look at, and he understands the anatomy very well.
Okay.
Wade is also just a joy to be around. He's one of the most charismatic members of the group. He interacts with people just wonderfully. So he's always the guy when, if we're having a tough day, we always go to Wade and he cheers us up.
Cheer you up.
Absolutely.
Good, good.
Doug Brandt also came down here originally with us. He's about 6'10", and he's a former NBA basketball player, so he stands out.
Can't miss him.
Exactly.
When you attend the cafeteria, you know, whoa, there's Dr. Brandt.
Absolutely, absolutely. And Doug is incredibly good at body imaging. So just everything basically from your diaphragm down to your pelvis, all the different organs. He's very good at that. And in addition to that, he's one of the best general radiologists. He's a jack of all trades in addition to his specialty. He can do pretty much anything. You just give him a task and he can get it done. I'm sure he learned that can-do attitude through playing sports all those years and growing up in rural Nebraska. He's just,
you got to do it.
Absolutely, he just gets things done.
Right. Well, and that teamwork from the sports side as well. I think that all plays well into it. Okay, I didn't mean to interrupt you.
No, not at all. Last but not least is Chris Porter. He's the newest addition to our group, and he has a really valuable skill, interventional radiology.
And that's new.
That's a very new area.
Right.
At least some of the techniques that he uses are very new. In the past, if you had anything that had to basically be rearranged inside the body, someone had to be physically cut open for a surgery, which, even though that's very safe when done by competent people, it entails some level of risk. Using our advanced imaging techniques now, we can, in some sense, operate on the body without having to make a large incision, without having to use stitches and things like that. Dr. Porter is amazing at working through these tiny little incisions, like building a ship in a bottle almost. He can do complex procedures, but people don't have the risks that they have when they undergo surgery.
Sure.
All sorts of things that he can do, particularly vascular work in the arteries and veins to keep people's arteries and veins working as they age and if they have any particular problems. He can take care of all that, and basically at the end of the procedure you get up and walk away because you haven't had to undergo a complex surgery.
And the anesthesiology, or the anesthesia for such a long period of time.
It requires much less anesthesia, although for some patients that prefer, we can still use anesthesia so they're not
There's some things
awake.
You just want to be asleep for. I know personally I'm kind of like, no, I don't need to hear. Just put me to sleep. I'll wake up when I'm done. It's all good.
Absolutely. But he is very good at that, and he had to do extra training for that. That's a skill that even in a very rigorous 4-year radiology residency, you need additional training to do the really advanced techniques. And he's gone and done that and did a wonderful job at a fellowship in Virginia.
Amazing. And so you've put this team together, and then there's yourself.
Yes.
And your specialty in the tomosynthesis and breast mammography. And so that was a whole separate specialty fellowship you did as well,
Absolutely.
Right?
So when we all got done with our residency training in 2010, Wade and Cale headed west to Kingman, and I headed east to Boston, where I did a year of breast imaging. Breast imaging is still, of all of radiology, it probably has the most art in addition to science. And so to really get good at it, you can't just read a book, you need to study under the people who do it really well. and the people at Massachusetts General Hospital do it very, very well. I learned a lot from them and had the opportunity to be trained on tomosynthesis prior to its arrival.
Okay, so how did you get that prior to its arrival? So they had like a...
They invented the technique and were working on the preliminary technology. They actually had been working on it for many, many years.
Wow.
And I was lucky enough to be training there right at the crux of it, coming from being an experimental technique to being available for patients in general. Exactly.
Now, when you were saying how you know, the breast imaging is almost an art as well as a science. Is that because of the composition, because of the mass tissue and that kind of thing?
That's precisely it.
Okay.
It's a unique part of radiology in that you really are just trying to answer one question, cancer or not cancer.
Right.
In other parts of the body, there are many possibilities for something to go wrong or be abnormal.
Okay.
In the breast, you're typically only interested in cancer or not cancer.
Right.
But there's a lot of variability in the way the breast looks.
Okay.
It's in some ways almost like a fingerprint. Every woman's breast can look a little bit different, which makes it hard. Every time you're looking at a new background, what's abnormal?
Each one's unique, right?
Exactly. So you really have to see a lot of abnormals to learn what it looks like and to develop a sense for what's not quite right.
Well, and I would think that that's another reason why it's so important for women to get that initial benchmark mammography done. What is that, 40 still, or is
40, absolutely. Okay. There was some confusion arising from some misinterpretation of earlier studies and the United States Preventative Services Task Force guidelines that were released and almost immediately revised.
Oh, good.
Now it's definitely age
back
40,
to 40, okay.
Every year starting at age 40.
Okay. And with that benchmark, I know that that gives then, as you're moving forward, something for you to refer back to, so you're going to know, oh, this woman has lumpy breasts, normal.
Right, absolutely. So, if you're looking for a subtle change, that's a lot easier to see if you know what it looked like before, rather than just having to look at it and find a subtle abnormality.
Right.
Absolutely.
And I think it's important, I know for myself, I had my first one when I lived in San Diego. And our imaging center, when I moved here, and this was before you came even, but they were able to contact my provider back in San Diego and get those images. So it's important for women to have that information so then they can have that benchmark still, even if they've just moved here to Kingman, know where you had it to begin with.
Absolutely.
Right?
That's the reason we have set up this relatively complex system where we can acquire people's mammograms. We've gotten mammograms for people here in Kingman from as far away as the Philippines and Indonesia, just so that we could do a good job interpreting their study.
Awesome.
It is so important. That's why we go to those lengths to make sure that women can benefit from that added cancer detection that comes with having previous mammograms available.
So we just have to constantly reinforce, and I know we do that throughout the year. Of course, in October, we really push hard, Breast Cancer Awareness Month, and May, we try to do that again for Mother's Day, you know, give your mom a gift, make sure she's had her mammo.
Absolutely.
Those kind of things, but the opportunity is there, obviously, year-round. And we have a number of different programs. I know KRMC works very closely with the Well Women program, so women who don't have insurance or have a high deductible are able to get extra assistance, and we just don't want any excuses, right?
Right.
to not get that.
Absolutely. We just got a grant from the Susan Komen Foundation as well, so we have quite a bit of resources available to help out people, regardless of what level of income they're at. In general, we like to help people get onto access care because that can help them not just with their mammogram, but if they have any other health needs in the future, it can help them with that. Good. But for everyone, there's ways we can help. And the hospital is a nonprofit hospital.
Right.
In some cases, when we haven't been able to find a program to help, we've just written off the care.
Yeah.
Exactly.
We're going to take a quick break, and then we're going to come back and talk about that more. So I hope you'll stay tuned because we'll be right back after these messages. We mentioned that 40 is kind of the benchmark age when you want to get your first mammo, and how did that age get picked? Welcome back to Your Health Matters. My guest today is Dr. Chris Johansen. Thanks again for being on the show, Dr. Johansen. And we've been talking about the importance of a mammography for women. We mentioned that 40 is kind of the benchmark age when you want to get your first mammo, and how did that age get picked?
Well, you know, it was picked based on a few factors. Wasn't
Okay.
just randomly picked. There's a few things that play into 40 as being a great age to start screening for
Okay.
mammography. We know by looking at studies of women who have undergone radiation that the breast is very radiosensitive up until about the age of 30. After somewhere between 30 and 35, low doses of radiation do not affect the risk of breast cancer.
Oh.
And we know that, for instance, if you follow women who are treated for lymphoma, which requires high doses of radiation to the chest,
Okay.
women treated in their teens have a very high, 25 to 35% chance of developing breast cancer throughout their life
my.
because of that radiation.
Wow.
You give that same high dose of radiation to women over the age of 35, and they don't show any increased risk of breast
That's
cancer.
interesting.
So we know that sometime after about age 35, the administration of radiation to the breast does not increase the risk of
Okay.
cancer, even at those high levels,
Right.
much less at the very, very low levels we use in mammography.
Well, and I was just going to, that segues well, because I know in tomosynthesis, part of the difference, even between tomosynthesis and the old mammals, is less, right? Am I saying that
So
right?
it's there's some new technology. Radiation dose in mammography is different than the rest of medicine because it's actually mandated by the Mammography Quality Standards Act. The government actually regulates how much
wow.
radiation can be
Okay.
administered in a mammogram.
Okay.
There's a maximum dose, and tomosynthesis stays below that maximum dose.
Okay.
There is a small increase in the amount of radiation used because you get both a 2D and a 3D image in the past. Now, we've just had a very exciting advent of technology that can take the 3D images and create a synthetic 2D image.
Wow.
So in that case, you actually end up using less radiation than an old 2D mammogram, in spite of the fact that you get all this extra information.
You're getting better pictures, better quality.
And less radiation. So it's really
Amazing.
win-win-win.
Right.
The amount of radiation that is decreased is not a huge amount, but it's still less. So that's a good thing.
Yeah, every little bit helps. And I think another advantage, if I recall, on tomosynthesis is that it's a little bit faster. I mean, the procedure is still kind of the same, but it's not quite as...
So the actual procedure itself takes about 4 seconds longer.
Wow.
4 to 8 seconds. It
Okay.
depends on the thickness of the breast. It's a small enough difference that most patients really don't know if they're getting an old 2D mammogram or if they're getting the newer,
Okay.
more advanced tomosynthesis study. The interpretation takes much longer. It
Oh.
takes 50 to 100% longer because you take a study that previously only contained information from 4 images to a study that can contain up to 300 or 400 images.
Oh my goodness,
So
I
it
had
takes,
no idea it was that many more.
Exactly. It takes a lot longer to read through, but that's okay. That takes longer because you have a lot more information that you
Sure.
can use to detect a breast cancer. That's been one of the things that's hampered the acquisition of tomosynthesis by many places because you have to have enough radiologists dedicated to reading it that they can
have the
get
time
through all the
to-
studies. Exactly. It's also a study that's not compensated right now, so we provide it here at no additional cost. So the same cost for a 2D mammogram that you would pay for anywhere, here at KRMC we add on the 3D portion
Extra.
without anything extra.
Well, and I know I've had friends with personal experience where with that tomosynthesis, you were able to see very small tumors very deep in the breast that would not have shown on a regular mammography for probably quite a while.
It's
till it
very
got bigger.
exciting. You
Yeah.
get to detect more cancers that may not have been detected on traditional 2D
Mm-hmm.
mammography, but what's more exciting for us, even beyond catching more cancers, which is of course exciting,
Right.
is the fact that we don't have to call back as many women
Oh,
for
that's important.
workups that don't actually end up with a diagnosis of a cancer. These extra workups are extra hassle, expense, time, they're emotionally
I
distressing.
was just going to say the concern. What do you mean I have to come back? Why?
Exactly.
You know, when you plant that fear almost from the beginning.
Typically in the past, up to 10% of screening studies have needed to be called back to
Okay.
be 100% certain that there's not a cancer hiding
Right,
there.
okay.
That rate has dropped as low as 4.5% with the use of tomosynthesis depending on the location and the patient
Mm-hmm.
population.
Awesome. So we've talked a little bit, and I know that we've said 40, but women can still, if there's a family history of breast cancer, it's probably important that they be checked regular, right?
Right, so for the average woman without any symptoms and without any abnormal family history, we recommend starting yearly at age 40.
Okay.
There are some exceptions to that rule. If a woman has a particular clinical finding, such as a lump, pain, nipple discharge,
Okay.
anything that's a clinical finding, we'll work them up with a mammogram from age 30 on.
Okay.
In that case, you'll also need a diagnostic ultrasound.
Okay. So insurance normally covers at the age of 40 for your screening, right? But
Yes.
you need a script, I believe, right, from your primary care. You go in for your well woman check, and then they'll give you a script to have an appointment to have your mammo?
Technically, you actually do not.
Oh.
It's federally mandated that any woman can go and simply sign up for a screening mammogram.
Oh, so they just call?
They can. Now, that being said, a team approach to medicine is vital.
Sure.
Any team of doctors can outperform a single doctor. Even if that individual doctor is the smartest one in the world, you're always better off having a team of physicians working on your behalf. So even though women can go and obtain a mammogram without a script or without having spoken with their primary clinician, we strongly encourage them to go and speak with their regular doctor. That's what's best for their health, and that's what allows us to do the best job for them. Their clinician can do a physical exam first, can talk to them about breast screening, determine what their screening needs are, and then streamline that process. They can come to us and get exactly what they need the first time.
That's great. So, and we talked about before the break that we have the Well Woman program and other opportunities to help with grants that the hospital's been able to get. So we want women to know the most important thing is just get that mammo. Not worry, because we'll help you find a way to get it paid for if you don't have insurance.
We don't want anyone to be turned away. We are the nonprofit hospital in Mojave County. Our job, part of our mission, the reason we exist is to help everyone, regardless of their financial means. So I would strongly encourage anyone with any economic situation to give us a call and make sure they get their screening mammogram. We actually have a breast health navigator, Jennifer Rosebrock.
Jennifer, she's been on my program before.
She's just outstanding. We're so lucky to have her here in Kingman. She cares so much, and she backs that up with a lot of knowledge and organization. She's helped so many women to get their appropriate tests done,
and kind of walks them through the process, helps them navigate through it.
Perfect. Far beyond even the economic implications of needing a study, Jennifer helps with everything. She just helps to alleviate anxiety, give people good information, and make sure that they always understand what's going on.
So again, we just can't reinforce enough the importance of why women need to get that first mammo. And as we talked about catching it early, as our program, as we call it, Catch It Early, the outcomes are so much better, right, if we catch it early.
Absolutely, and they're better in many different ways. The cure rate, of course, is the main thing we're concerned about. Very early breast cancer can be treated with near 100% cure, or near 100% 5-year survival rate. That survival rate goes down as the cancer gets larger and starts to spread to the lymph nodes and to other parts of the body. In addition, the treatments that we have to use to get those reduced rates are more invasive, they're more expensive, and they're just generally unpleasant to have to go through. If you can avoid them, you absolutely want to.
Okay, so that's, again, the importance of catching it early, getting in there and getting that mammogram done. I wanted to just go back a little bit, Dr. Johansen, because we talked at the beginning of the program about this awesome team of doctors you've put together, and you mentioned we have a 6th one that you're looking at, so that'll be even more exciting. And you, besides all of the offer you have here at KMC, you also have formed your own, the High Desert Vein Center.
Yes.
And what does that do exactly? What do you guys do there?
So High Desert Vein Center is off on Stockton Hill, just south of the hospital. It's an area where we can use some of the percutaneous skills that we mentioned before, the ability to treat things without using full-blown invasive surgery. And in particular, we work on venous disease of the lower extremities.
Okay, so that's the veins.
Exactly,
right?
yes.
So things like varicose veins?
Varicose veins, there's lots of different venous issues that people can have, and really the best way to figure it out is to just come see us and see if there's something there that could potentially make your life better by being treated. A lot of people think about vein centers from a cosmetic point of view, which is a portion of what they do, but especially here in Kingman, we have people who have really debilitating symptoms. Their legs hurt. They're not able to get up and walk around, to exercise, to be healthy because of the venous disease in their legs.
That's what I was just going to ask you. It's what kind of symptoms or what would be the issues that a person would experience that should raise a red flag and say, I need to get this looked at.
Besides actually looking and seeing if there are varicosities, dilated veins in the lower extremities, things like pain, burning sensation in the legs, numbness, any sorts of symptoms like that, or discoloration of the skin, all can be symptoms of venous disease. It can
and
be
is it
difficult.
Usually it's a circulation issue, basically,
Right.
is the veins aren't working quite for one reason or another?
Absolutely. So as your body pumps blood down to your lower extremities, that blood has to come back up, and that takes some energy to get that blood to flow back up, and your veins have tiny valves that help the blood to move up and not flow back into the lower extremities. If those valves with time become incompetent, so they're no longer doing their jobs, you can get a lot of pressure built up as that column of blood tries to flow back into the lower extremities. That's painful. It can lead to decreased blood flow in the lower extremities, which can cause all sorts of other medical problems, especially if a person also has obesity or diabetes. Sometimes the key to getting these other symptoms under control is getting your venous disease under control so that you can exercise and be active.
Wow. Awesome. Well, unfortunately, we have to end the program now. We're going to have you come back and talk more because obviously there's more to learn from you.
Thank you so much for having me.
Thank
I appreciate
you.
it.
And I hope you guys learned something new today because I know I did every time I do this show. Join me again next week when I'll have another exciting guest on the program.